I have 8 o'clock, so I would like to go ahead and start this month's Next Generation Editors Journal Club, which is our third installment of the ASJ Journal Club series for 2022. My name's Ryan Austin. I'm a plastic surgeon in practice in Toronto, Ontario, and I'm the lead of the NGE section. And I'd also like to introduce Dr. Maryam Zamani, who is a fellow Next Generation editor from Oakville, Ontario, who also happens to be in practice with one of our discussants tonight. She's going to be our discussion curator, and she's going to be moderating the chat box for us. So if you have any questions, make sure that you open up the chat box, type your questions in, answer the poll questions as they come up. We want to get as much interaction and any questions that you have for our discussants tonight. Tonight, we're going to be reviewing an article from the May 2022 issue of ASJ entitled Treatment and Prevention of Periprosthetic Capsular Contracture in Breast Surgery with Prosthesis using Leukotriene Receptor Antagonists, a meta-analysis, and the accompanying commentary article. We're fortunate to be joined by Dr. Andrew Weinstein, one of our fellow Next Generation editors from New York City as well, who's going to be providing us with an overview of this month's article. We also have two excellent co-discussants here with us tonight. First up, we have Dr. Julie Khanna from Oakville, Ontario. If you were in San Diego for the aesthetic meeting, you probably recognize Dr. Khanna from her stints on the main podium, but she is a graduate of the University of Ottawa Medical School and completed her residency in plastic surgery at McMaster University in Hamilton, Ontario. Dr. Khanna is the past president of the Canadian Society of Aesthetic Plastic Surgery, and she has published extensively on her experience with aesthetic breast surgery as well. So thank you, Dr. Khanna, for being here with us tonight. Our second co-discussant for this evening is Dr. Marissa Tenenbaum from St. Louis, Missouri. Dr. Tenenbaum received her medical degree from Washington University in St. Louis before completing her general surgery and plastic surgery training at WashU. Dr. Tenenbaum is now an associate professor of surgery and director of aesthetic surgery at Washington University School of Medicine. It also just so happens it was Dr. Tenenbaum's birthday yesterday. So on behalf of all of us here tonight and around the world, we'd like to wish you a happy birthday. And we're glad that you stepped away from your celebrations to join us to provide your expertise. So without any further ado, I will hand the screen over to Dr. Weinstein for his review of tonight's article. Dr. Weinstein.
Thank you, Dr. Austin. As Dr. Austin mentioned, I'll be providing an overview of the journal article. As we all know, capsular contracture is one of the most common complications after prosthetic breast surgery, and leukotriene receptor antagonists, in particular montelukast and zafirlukast, have been studied off-label for management. Yet, as the authors note, no consensus has been reached about LRA efficacy. And in terms of the mechanism of action, just as a review, they're thought to block the inflammatory mediators secreted by immune cells from binding leukotriene receptors on smooth muscle cells and having the following two effects related to capsular contracture. The first is relaxation of myofibroblasts that are in the capsule. And the second is reduction of the inflammation and scar tissue formation. The author's objectives were to assess the efficacy of montelukast and zafirlukast on preventing and treating capsular contracture among prosthetic breast surgery patients in the literature. To achieve this, they conducted a systematic literature search of articles in English of the following databases: PubMed, Web of Science, Embase, and Central, consisting of clinical studies regarding capsular contracture prevention or treatment with LRAs published through 2021. And then they performed a meta-analysis following the PRISMA guidelines. And as you can see on the right, among the 127 articles that were initially identified through the search, 6 met eligibility criteria and were included in the study. In terms of the eligibility criteria, the participants were patients who underwent breast augpexy, implant-based breast reconstructions, and their revision, so both cosmetic as well as reconstructive breast surgery. In terms of the intervention, patients received either montelukast dosed 10 milligrams once daily for 3 months, or zafirlukast dosed 20 milligrams twice daily for either 3 or 6 months. The comparison group was the no treatment control group, and the outcome was the presence and degree of capsular contracture as measured by the modified Baker scale. And modified Baker scale is similar to the traditional Baker scale with the addition of a grade 1A corresponding to the implant being undetectable. Otherwise, grade 1B would be the traditional grade 1. Capsular contracture was defined as grade 1B or higher, and success as relating to prevention of capsular contracture was defined as no grade increase, whereas the success regarding treatment was defined as at least half a grade decrease in capsular contracture. Among the 6 studies included, 3 were cohort studies, 2 were randomized controlled trials, and 1 was a non-RCT. Together, this added up to 2,276 breasts, of which 775 received treatment with an LRA and 1,501 received no treatment. And table 2 here just shows various characteristics of the studies. In terms of the first column, 2 of the studies included textured implants. The others were all smooth. 2 of the studies included subglandular placement. The rest were submuscular. 1 study included breast reconstruction. The others were focused on cosmetic breast surgery. And 1 study included the transax approach. The others were combination of IMF and periareolar. Average follow-up time was 5 to 39 months. Overall, the authors found that LRAs significantly prevent or treat capsular contracture, and this statistic was associated with a high degree of heterogeneity. The authors then performed a subgroup analysis, first comparing the effect of montelukast to that of zafirlukast, and they found that montelukast significantly prevented or treated capsular contracture, but not zafirlukast. They then went on to compare prevention to treatment and found that LRAs significantly prevented the progression. So treatment with LRAs was significant, but the same was not true for prevention. The authors concluded that montelukast dosed 10 milligrams once daily for at least 3 months may be effective in capsular contracture treatment, but then again, this is an off-label use. But that the role of LRAs in prevention remains unclear. And they also add that it's important to keep in mind that adverse effects are possible and LFTs should be monitored due to the risk of hepatotoxicity. And in addition, it's important to note that there is a box warning for montelukast, which we may discuss subsequently. Thank you for your attention.
That's an excellent review. Thank you so much, Andrew. Dr. Khanna, I'd like to get your thoughts after reading this meta-analysis, and what do we make of this? Where do we take this?
Well, as I was saying to you last night, Ryan, one of the first things that surprised me was we've only been using it, or the data is showing from 2002, and I really old because I feel like I've been using it longer than that, and it may just be that the data wasn't there. It was an interesting study to read. I was actually hoping that it was going to say to me, we were vindicated for using it, and I didn't walk away truly with that feeling. What I walked away with is a little bit of confusion. They had 127 studies and only 6 that they included because of multiple exclusion criteria, and I could see why. That's a pretty small number. We also then were looking at large groups that were textured implants, and then they referred to the fact that that automatically decreased the rate of capsular contracture, even in their discussions. So, 2 studies out of the 6 were with textured. So I was a little concerned about how do we interpret this data. The other thing that really got to me is 1A CapCon. I would like to know which one of you guys cannot examine a breast and examine a breast and not tell that there's an implant in there. Like, I'm sorry, I don't understand that, because we can say it's really good. We can't see it. I understand that and I respect that. But when we examine a breast, we can feel an implant. And to me, that was a bit of a fallacy. So they then included that CapCon was 1B and above. Okay, well, so to me, that means every single patient's got CapCon. So I don't understand how they only had 2,000 patients, because that should have been every single patient that was touched. The other thing that I found really interesting about this is improvement was noted to be 0.5. Okay, again, this scale is a scale of ones. If we ignore 1A, 1B, how do we take a scale of now 0.5 and show an improvement? It's very subjective, right? We all know CapCon is very subjective. And to me, one of the most important things is, can you see it? Can you see it with hands up? And what does your patient tell you? And is there a difference from right to left? Because to me, that's much more important than just a subjective classification. So I was really disillusioned with how they looked at it and what their planning was. And a lot of these, some of these points, Dennis also brought up in his commentary to it. So I think they jumped to a lot of conclusions. And the two big things that I saw them do is no evidence for prevention. I think their numbers probably just couldn't accept that or show that. And I respect them for saying that. I don't think you can say maybe there isn't. I actually don't know the answer to that. But I don't know if the data actually proved that. The second thing that they said was interesting was the Zafir Lucas has no difference. And they gave multiple reasons, but the numbers were so mixed that I'm not sure if that was clear. And then they stated things like, well, it's BID, maybe they weren't taking it. So there seemed to be a lot of assumption. They didn't have data behind it, but they were just assuming that this is why it's a problem. This is why it's an issue. The other thing that really bothered me was one of their conclusions was monitor liver function. And in no place does it say it in the patient, in the monograph. It just says, be aware of using this medication because it is excreted by the liver, to use it appropriately in patient with liver function. They reported one case with the Zafir Lucas cases saying that they had liver function failure, but they never went back to the fact, did the patient already have it and this exacerbated it? They didn't get into any detail. And I think that's what you worry about with the meta-analysis, that you're kind of really looking at things really superficially without looking at the depth, and you're making big sweeping conclusions. And that worries me a little bit because I don't think the data was there enough to support that. I think it showed treatment of CapCon, there can be a change. It's really surprising that we don't have great randomized trials to looking at this, because it is something we all do. And we maybe need somebody like Caroline to just put us all on a whip and make us do it. But I think really I was a little underwhelmed. I was really hoping for a lot more.
Thank you so much. I think you bring up so many excellent points. Dr. Tenenbaum, I'd like to see if you have anything to further Dr. Khanna's points, or any other thoughts in reading the article and the commentary.
Yeah, I mean, I thought, Julie's summary was excellent. And I think Dennis is on as well, and his commentary was excellent. I think, I couldn't agree with Julie more. I think, I don't fault the authors necessarily for this, but, a meta-analysis looking at flawed studies is, frankly, I don't know what you really can take away from it. And I think the authors tried to take things away from it, but ultimately, as Julie already mentioned multiple times, I think they were making a lot of leaps and assumptions. And I don't know that I would really read a paper like this and say, okay, this is going to actually alter my practice because I believe the data. And I also agree with Julie. I think there's no reason why we shouldn't have some good data on this. So many people use it. That we could do a nice RCT, because frankly, any one of us as an individual, it would likely be underpowered, as a lot of breast augmentation studies are, simply because thankfully complications are fairly low. So we need a lot of power, which means we need bigger studies. However, to me, the biggest issue with this problem, and again, of course, Julie, she's so brilliant, she already brought this up. I think the definition of capsular contracture is incredibly flawed. So now we're trying to study something that we don't even have a good grasp on its definition. It is a subjective, as she already elucidated quite well. It's a very subjective measurement. I agree with Julie. If you're a plastic surgeon and you can't tell that there's a breast implant in place, even your most perfect AUG, something's really wrong. So even the description of the classification is already wrong. And then one plastic surgeon to the next, to your nurse, to the resident, to the other plastic surgeon, the difference between a 1 or a 2 or a 3 or a 4. I mean, they're all shades of gray. So, as she mentioned, maybe you could, come up with a really fancy study using, actual tensile strength, using weight management, a disc, displacement test, things like that. It would be really hard to get everybody to do that. But really, truly, that might be the only way to actually classify this. People talk about capsular contracture all the time, and we all know what it is, but we simply don't have, in my opinion, really strong agreement on exactly how to define it. And therefore the science around it is going to be bad. And that's not the fault of any author per se. It's the fault of lack of definition.
And what about as we shift from textured implants, maybe somebody, we've seen a shift away from textured implants in North America to more smooth devices, not the same necessarily overseas, but is that going to, for our attendees who are maybe making that change or thinking of making that change or kind of in the process and seeing these patients, what about the assessment of capsular contracture, the difference between those devices and how we make those assessments? Does that change at all, or is the system just so flawed that we have that it kind of covers both but doesn't cover them well?
Well, I think there are way too many variables besides texture. I mean, Dr. Austin, I think you have a nice paper showing that, the rate of capsular contracture actually is not higher in a subfascial smooth implant. So, a lot of the dogma around what we used to think 10, 15, 25 years ago, I'm not sure that is still dogma. So even the difference between textured and smooth, I think, evolution of techniques, evolution of gel type, evolution of a lot of different things. I'm not sure that I really still wholeheartedly believe that anymore. Maybe it's true, but again, there's a lot of those dogmatic things that I think have changed. And unfortunately, many of the studies we have in these types of, implant, whether it's for reconstruction or aesthetic purposes, are not necessarily the highest quality studies. And so, some of that dogma, I'm just not sure we can believe it.
I think one of the other issues that we have to look at is when we're talking about CapCon, we really need to talk about time of onset, because I think it's a really important point. Is this happening in the first year? Is this happening at 5? Is it happening at 10? Is it happening at 15? Because I think the etiology in that group, each year's subset is different. We could talk about surgical technique. We could talk about genetics. Okay, it's there, right there. Is it bilateral? Is it unilateral? There are so many factors. I think that's why it's hard to study, because it really is such an enigma, and it is so variable. If you ask me a textured versus smooth, long history of a textured user since 99 till 2016, and my CapCon rate was super low, and it would all be over 10 years. So what was happening all of a sudden in 10 years? That's when they would be coming in going, oh, you have a sore breast. Oh, by the way, did you have an infection, car accident, anything? And oftentimes you would elicit, I had major dental work, I was in hospital. This was even before COVID. And let's not even get started with either having COVID or having the vaccine. Like transient CapCon with a vaccine or actual CapCon after COVID. I've been seeing both. I mean, I'm not seeing huge numbers, but I've seen enough that I went, wait a minute, why is this happening? So I don't know, Marissa, are you seeing that?
Absolutely. And I've, again, just the inflammatory cascade, I've had a handful of patients that, you think they're infected and, but they're not acting quite like your typical infection. And sure enough, they're 2 weeks or 3 weeks out from a COVID infection or a vaccination. I've definitely seen that a handful of times. It's very frustrating.
So everyone, make sure you type your questions if you have anything you'd like to discuss or questions for our discussants. make sure that you type them in and also answer the polls as they come up. So what I'd like to talk about is how do we implement these things? Because I agree. I think that reading this study, one of the things, it's great to see the study because it's something that we all do. But when you see this meta-analysis that has 6 papers and it's got these flaws, it really says to us, okay, we don't have the best data. We haven't really studied this and we don't know as much about it. And so I think that this is a great study to publish just to show that, to lead that springboard to that double-blinded control study, as Dr. Glicksman posted in the chat. So how are you using these medications in your practice currently? Are you using them for prophylaxis and primaries? Are you using them for immediately off the bat for a patient that's undergoing a capsulectomy? What about that patient who shows up with that 2-week post-COVID vaccine tightening around the implant? Do we put these patients on these medications? Dr. Khanna and then Dr. Tenenbaum, how are you using these leukotriene receptor antagonists day to day, week to week, month to month in your practice?
I'm not a big prophylactic user at all. It is, for me in my practice, it's that it feels a little bit firm, usually with a history of a previous CapCon. I'll be very quick to use it. I usually give a 3-month or a 6-month prescription and then follow up. And I often tell them at 3 months, if it doesn't feel better, then follow up earlier. But if you feel like it's improving, continue to 6 months. I don't tend to repeatedly use it either. It sort of gets there. Now, I'm also old school enough, don't quote me on this, strike it from the record. I still rarely, but occasionally, will do a closed capsulectomy. And I might use it in that group where I'm doing a closed capsulectomy, just feels a little bit firm, a little bit unexpected in that first year in that secondary case. I know it's a new implant. I know how far I can get what I can get away with. And I'll use it in that group a little bit as well. But it's not something that's an everyday occurrence. Sometimes I'm using it just so you're doing something. And, I think sometimes you need time and you just want to let things settle. It just feels a little bit firm. I don't know. I'm not convinced. I have to be honest.
And are you using one or both of these medications, just to clarify?
Just singular.
Okay. Dr. Tenenbaum?
I'm very similar. I really have only used singular. I will occasionally add high dose vitamin E that I just tell them to get over the counter. I rarely would use it prophylactically, and I would be more likely to use it in that early, it feels a little firmer. As Julie alluded to before, you can tell there's a difference between the two breasts. I'm very quick to put a patient like that on it. And I agree. I usually do 3 months follow up. If they're improving or at least not worse, I'll extend it to 6 months. And of course, if they're not better or they're symptomatic and they're bothered by it, then I'll go to surgery.
And for revision cases, let's say that you're doing a capsulectomy, are you putting your patients automatically on these medications right after surgery? Are you waiting to see how they do? How do you manage the revision?
If I'm operating because of CapCon or that's a part of the revision, then yes. But if it's for something else and they don't already have CapCon, then no, I'm not routinely using it.
Yeah, and I would be exactly like Marissa. If I'm operating for CapCon, and especially if it's a newer one, like if it's somebody who's 15 years later, I don't know. To me, I'm not going to use it in that group.
And one of the things that you brought up, Dr. Khanna, and that Dr. Weinstein also talked about was this concept of liver failure, liver enzyme bumps, liver disease. So how are you counseling your patients before you put them on these medications? Are you doing screening liver enzymes? Are you following those up? What do you do in regards to this dreaded liver failure associated with these LRAs?
Well,
I didn't like reading
that.
Were
you shocked about that?
Yeah, I don't test liver function. I mean, if somebody has a history of liver disease or something along those lines, of course, I'm going to be wary, but in an otherwise healthy person, I don't. I will tell you, and this may be off topic a little bit, one of the side effects that is a listed side effect, but that I actually have seen personally a handful of times is depression. on Singular. And you see it more commonly in patients who have a history of depression, anxiety. So I will tell them, hey, if you're, this is a weird side effect. Most people don't get it. But if you feel like you are a little more down and you're not sure what's going on, just stop taking it and call me, because there actually have been some reports of pretty severe depression and with this. So that's the thing I actually warn them about, not the liver.
And that's
sorry.
Go ahead.
No, I just think, Ryan, if they have liver function issues, then I'm just really tending not to use it. But otherwise, routinely, I've never ordered it. And I did actually look at the monograph yesterday to see, did it actually recommend it? Because I'm like, have I been avoiding doing this? And it wasn't recommended there. That's why I was really surprised that they jumped to that conclusion in the study as well.
I agree. And, just to springboard from what Dr. Tenenbaum was saying, I'd like to actually throw back to Dr. Weinstein, just because he has an excellent update, just so that we're all aware of this kind of issue with mental health exacerbation associated with these medications.
Sure. So, in preparing for this journal club, I did come across this FDA box warning for montelukast, trade name Singular. As we all know, it's FDA approved for the treatment of asthma and allergies, in particular allergic rhinitis. And this warning, which came out back in 2020, reported seeing an increase in a wide variety of mental health side effects, including completed suicides. Of course, this is all observational, but it was concerning enough for the FDA to issue this warning. And so I just wanted to bring that to everyone's attention, and I'll throw it back to you, Ryan.
No, I think that's such a profound thing for us to talk about tonight, because everybody gets scared of liver failure, liver enzymes, liver dysfunction. But this is probably the real stuff, as Dr. Tenenbaum saying, that is going to impact your patients on a day-to-day basis. And to actually make them aware, for, number one, we need to be aware of it and know that this is out there, so that we can then counsel our patients appropriately for not the 1 in a zillion, 1 in a trillion thing that's going to happen, but for something that's gone to the point that the FDA is actually put a black box warning on this medication that we're using off-label for this treatment. So one other thing that I'd like to get your thoughts on is, just as Dr. Hammond mentioned in his commentary, and it was an excellent commentary, and he's actually on here tonight. I saw him join on. So if you have any thoughts, please let us know. But what about this concept of other anti-inflammatory medications as part of a routine post-operative protocol to try and minimize this inflammatory cascade, not necessarily jumping to these leukotriene receptor antagonists, but anti-inflammatories, just to try and drive that down so that we don't see these as a more preventative measure, as opposed, as a prophylactic treatment. Do you use any anti-inflammatory treatment protocol, or what are your thoughts on that, Dr. Khanna, Dr. Tenenbaum, and Dr. Hammond?
I don't use anything prophylactically. I mean, NSAIDs are part of our post-operative pain management course, but for a short period. I mean, we've gone through the era that we were there were people injecting steroids into saline implants years ago for that exact same reason. And again, it had other issues, more than a few issues. So no, it's not a part of my routine prophylaxis.
Same with me. We use, some anti-inflammatories for post-op pain management, but for a very short period of time. I'm not routinely thinking about it for CapCon.
Dr. Hammond, any thoughts, or would you like to comment? Oh, we don't have your sound there.
You'd think I would have figured that out by now.
Thank you.
Yeah, these are really great comments that people have made, and they're spot on. It's number one, I congratulate the authors. I think we need to encourage people to look into this. We all know the limits of a meta-analysis. Basically, you're trying to overcome flaws in the study by increasing numbers, so to see if there's something that you can draw from the data. And as has been stated, it's not entirely convincing that these medications are going to be helpful, but still many of us do use them. Now, I've taken a really aggressive response to capsular contracture, and I do use some medications prophylactically and in treatment to help me. And that might be just a bit because of the nature of my practice. I see so many revisionary cases at this point. So mine is not a primary AUG, 1% capsular contracture, hardly ever see it anymore kind of situation. I'm dealing with capsular contracture pretty routinely on a daily clinic basis. And because I'm seeing people, this is their 5th, 6th, 7th operation. And I'm desperately searching for a way to bring this down to a low roar, down to the 1% to 2% range in these kind of people. And so one more point, I'll tell you what I do, and that's we're still not 100% sure what causes capsular contracture. I think clearly biofilm is somehow related into that whole process, but that's not the whole story. There's other things that pop in there, I think. And so ultimately, I think proper surgical technique, and that has been, going back to our good friend John Tebbets, who we all know has just recently passed away, was really one of the champions of getting our technique in order. So no more blunt dissection, primary hemostasis, creating the cleanest pocket we can, washing our hands, doing everything we can to create a sterile environment for putting this implant in. I think most of us do that sort of stuff. But beyond that, even in those scenarios, we're going to see capsular contracture. And I think that someday we're going to develop a medication regimen that's truly going to be useful, because we're trying to prevent the body from doing what it wants to do to a foreign object, which is to encapsulate it. And so currently I do use Singular, 10 milligrams once a day for 6 weeks, but I also put a steroid taper on there. So I'll give them 40 milligrams a day for 5 days, 20 milligrams a day for 5 days, and then 10 milligrams a day for 5 days. And that comes from my experience with pyoderma gangrenosum, because I've seen that disease several times over the years. And as you know, the treatment for that is much more aggressive steroids than that. And I've seen that just stop pyoderma gangrenosum in its tracks. So I know that there's an effect by taking these medications. And so I've tried to add that to my regimen to try to control that early inflammatory response to the implant. And I use it basically in every case. I use it in primary AUGs and in revisions, because theoretically I said, listen, if I'm going to give this to somebody in a revision, I'm going to give it to somebody in primary AUGs as well. Now that's medication 1.0. I'm looking forward to the day where somebody can tell us, here's the medication regimen you need. I think it's going to be ultimately a multifactorial medication strategy, attacking inflammation from several different standpoints. And then you can also talk about delivery. So perhaps an oral delivery of an agent is not the best way to go. Who knows, someday in the future, we maybe have something that we can attach to the surface of an implant, which I think is really an exciting way to think about this. So to answer your question, yeah, I do use medications to do this. And like I said, I use a steroid taper coupled with Singular. And I can't say I've ever seen a complication related to that until recently. Just this past week, I had a lady tell me that she was concerned about getting a little depressed on the Singular. First time. So I really appreciate everybody's comments on that.
That's great. Thank you so much. Dr. Khanna, anything else or anything to further follow up on that?
I think what Dennis said is exactly right. What Marissa said is exactly right. This treatment of this is going to be a vicious cycle. And really, I think we are working really hard towards trying to figure out how to prevent it. And I think, all our late Dr. Tebbets taught us so well, and confirmed Tebbetite myself, but maybe we're still searching for the perfect implant. And maybe it's what's on the outside, maybe what's on the inside, maybe what it's coated in, maybe what we wash with. I don't know what the answer is. And I think we do need better studies at quantifying it. When you've got data that's showing it, you have con rates from 2% to 43%, what's the real answer? I think we really need to just have a real group discussion and analysis of the whole process and the whole disease, and better looking at pathology as well.
Dr. Tenenbaum?
Well, I mean, if we could figure out the answer to all types of scars, right? Hypertrophic scars, keloid scars, capsular contracture, and all the different factors that go into capsular contracture, we will all be extraordinarily wealthy individuals. So, I mean, this is sort of, this holy grail in plastic surgery, right? It's not just the capsule around an implant. It's all kinds of ways the body reacts to scar and how to mitigate that. Because, the truth is, some scar is a good thing, right? Like I know we're at 7:36, so I don't want to completely go off the rails, but all of us who do breast surgery, and especially revision breast surgery, sometimes the capsule is our friend in a lot of ways. We want some capsule. It's like we want to be able to dial in the exact amount of thickness and tensile strength that we want. If we could do that, we wouldn't need all these meshes and, everything else, right? So we need to learn how to control scar rather than completely eliminate scar.
Well said, Dr. Hammond. I see you have your hand up.
Yeah, well said. Absolutely. And the reason that's really key, what you just said, is that we've seen situations now where there's essentially no capsule. And that's a problem, because then you lose your inframemory fold, you lose the lateral contour of the pocket. There's a new implant that's going to be coming to the United States. And I don't want to get into disclosure of interest and everything, but it's got a surface on it that creates like a smooth wall saline capsule, so that filmy next to nothing kind of thing that you see sometimes. And that is almost the reverse problem. You have nothing to support your implant. So to dial it in is really, man, I don't know if we're ever going to get there. But the one thing I would say, I'd back up, just even not to get into the weeds here, but just the theory of capsular contracture. Basically, I don't think smooth versus textured doesn't really make any difference, because it's a foreign object. And we're trying to prevent the body from doing what it wants to do to any foreign object you put inside, whether it's a pacemaker or an artificial hip or an insulin pump. They're all going to form a capsule around them. And what we've got to do, like Marissa said, is try to come up with a way to modify that capsule and that body's response to that device. Now, that'll help us initially, because you touched on this a little bit earlier, the early capsular contracture, the 6-week, the 3-month kind of capsule. What in the world is going on with the 10-year capsule? You see somebody that's had an implant in for 10 years, and all of a sudden they get hard. Well, first thing you got to think of, is it ruptured? Is there some reason for there to be a new source of inflammation there? And again, we're really troubled by a lack of data. Was it, like Julie said, is it with a visit to the dentist? Was it a ruptured device? Was it a COVID vaccine that caused some sort of something happened to trigger an inflammatory response around that device? And I don't know if sometimes we can even know what that is. So it just remains, capsular contracture is still just this conundrum that we're still trying to work with.
Is anybody...
Go ahead.
Sorry, I'm sorry, Ryan. Because you just brought that up, Dennis, because dental prophylaxis. So we talked about prevention with medication, Singular. I've been doing it for a long time. Like since 2008, all the dentists would tell my patients I'm crazy. The pharmacy would tell the patient that I'm crazy. I'm like, just call us, we'll give it to you. And then, now it comes up in the 14-point plan. But how long? How much? Pre and post? Just one dose? Like, what other things are we doing to try and prevent capsular contracture on a regular basis, other than Singular?
Well, I hesitate to bring this up, but it's a little rough. But I mean, every time we go to the bathroom, you can every time you brush your teeth, you can temporarily shower your system with some bacteria. And so it's just so hard to know. And that gets to, again, backing it up, is it truly a biofilm situation? Clearly that plays some role somehow, but we just don't really know for sure.
And so, Dr. Khanna, what do you do then for prophylaxis? Just seeing as you brought it up, for patients going to the dentist, what's your treatment?
I've been doing one dose preoperatively, 1 hour, pre-dental treatment, 1 hour, and that's it. And does it make me feel better? It makes me feel better. You know, like Dennis said, you know, super low capsular contracture rate, less than 2%. You know, is that part of it? I'm loath to give it up. I've been doing it for so long, you know. Plus, you're following your all your points. You've been doing triple antibiotic wash. I never gave up Proviadine when they told me to. You know, I didn't listen. I just kind of quietly used it on the side, and then you're kind of scared to stop anything because you're like, okay, the rates are good. I don't want to mess with this, but do I have good data to support it? That's not a good reason to say that. So we need better information, more concrete information, and maybe more meta-analysis studies of multiple people doing different things with good data to say, what does it actually mean?
Dr. Hammond?
Yeah, I just wanted to jump in. You touched on something that's really what makes some of this so hard to sort out, and that is that the grading or the description of capsular contracture is all over the place. Now, there was a system that was used in these particular papers, but if you go into the literature, there's like 10 different systems of the Baker grade, which goes all the way back to the very first one, which was just an addition to a monograph from Baker that was finally formalized by Scott Spear. I'm going to have a paper coming out in the journal in a few months that I'm hoping will be helpful, because what I do is I look at capsular contracture with regards to surface area, because that's really the variable that changes. When you get capsular contracture, the surface area of the pocket contracts down, and then as it starts to wrap around the implant, that's when you start to feel firmness. Well, you can examine, as you all said, all of us can feel an implant in a breast. If you squeeze that breast and you can move that implant around so that the space is bigger than the implant, that is not capsular contracture. That everybody could identify. Anything other than that is classified as an inflammatory response around the implant. You can go to the point where they're equal, but if there's any sense that that surface area has clamped, that's capsular contraction. And so I think that that'll be helpful, or I'm hoping it'll be helpful on setting the ground rules for what is capsular contracture, so we can start to do some of the studies that we're talking about here.
But Dennis, are you implying that the capsular space is larger than the implant itself? Because
Exactly.
in multiple cases, I would argue that they're close, and to perceive movement within that capsule would be difficult. You know, you feel a soft breast, but I don't think I'm actually feeling a completely moving implant in that capsule. Definitely in some of the older saline ones, like, you know, you can definitely move it around, but I've got good mobility within the breast. But I would argue that I'm not sure if it's actually within the capsule. So,
well, the point you bring up is true. There are some people that do have a capsular contracture. So the scar tissue implant mass can be pushed around inside but if you squeeze, it's a subjective thing. There's no way you can not make it subjective. But if you squeeze that implant, you get the sense that it's not moving around inside that pocket. And those of us that do a lot of breast reconstruction are going to know exactly what you're seeing, because a lot of times it's a problem. You know, the pocket is so big, the implant actually falls off to the side. Patients hate it. That's like the nth degree of that problem, that pocket that's bigger than the implant. But I've been using this for a few years now, and it's proved to be quite useful, because if they're a grade 0 at 6 weeks, and then you examine them a year later and it's a little bit tight, that's capsular contracture. And so I think it'll be I'm going to throw it out to you guys, and you can use it when the paper comes out. You can see what I'm talking about. But it gets to the point where we've really got to come up with a solid way to describe capsular contracture so we can all talk about it.
maybe it's ultrasound. Maybe it's ultrasound dimensions of an implant and comparing it to what the actual implant is. Because to Dennis, to your point, it's when the capsule is smaller than the actual dimensions of the implant. And maybe that is a concrete way of saying, if you're measuring the diameter of an implant on ultrasound, which we should be able to do, and it's not the diameter of the implant you put in, and what is the percentage change
No,
Maybe
you're
that's
exactly
how we
right.
should grade it.
Yeah. Because if you could lay the patient flat so that the implant would lay against the chest wall and then do
Yeah.
an ultrasound, if you saw no wrinkles,
I
that's
just
not
thought of that
capsular
just
contracture.
now.
Yeah. If you saw wrinkles, that's capsular contracture. So
Yeah.
yeah, absolutely.
There's so
That's
many
our
great
next study,
ideas.
Dennis.
Yeah, there you go. There's so many great ideas coming out of this journal club. It's amazing. I'd like to throw to Dr. Zamani. I appreciate we're coming towards the end of tonight's session. So, Maryam, what's been going on in the chat box? What are the polls saying? We've had some amazing discussion. What's going on with our attendees?
So I think the discussions have been so fantastic by all our expert discussants here that everyone's just really absorbing it in and really just trying to integrate what they can into their practice and just reflecting on the methodologies that we're currently using and all the big questions that we've discussed that still need to be answered by higher quality studies. So no real questions have come up, and I'm sure it's because of, again, a lot of that reflection. So based on the polls, it's a lot consistent with the varieties in our practices right now. A third of our participants have used LRAs. Most don't use it for prophylaxis of primary breast augmentations, but over 60% have used it in revision cases. Most are using Singular or Montelukast. That's kind of is the most common and familiar to most of us, which is consistent. And like we've discussed, the consideration of liver function tests is something that's new. It's not indicated in the packaging for the product either. And so most don't follow LFTs, although about half do still counsel their patients regarding potential for liver damage. And I think one of the most important things that's come out of this discussion that may be new to a lot of us is the black box warning regarding mental health issues that can come along with Singular. And as we know, a lot of our patients do have, certain mental health struggles, and that's really important for us to all reflect on, as 60% were unaware, myself included prior to our discussions earlier, and but some do discuss mental health implications when starting Singular with their patients. So that's all good, and I'm sure that moving forward, now that we've had this discussion, more of us will routinely utilize this as a jumping point to ensure that we're checking in with our patients and giving the appropriate precautions when starting them on this medication.
That's amazing. And, we're always looking for action items from these journal clubs, and, for our attendees to be able to take something practical from these publications and take it from the pages of ASJ into your practice. And I certainly think that we've done that tonight. So I'd like to congratulate the authors. I would like to thank Dr. Khanna and Dr. Tenenbaum for joining us tonight as discussants, and also Dr. Hammond for your commentary, and also joining as a guest discussant and bringing up all of your points and expertise. So we will sign off. I will let everybody know we are changing these journal clubs to a bi-monthly format. So we will be back in July with the next NGE Journal Club, and it will be moving to every other month, the second Tuesday of the month. And for those of you who don't know about it, we have started and continued on the ASJ and the ASJ Open Forum podcasts. So if you're interested in getting your ASJ content in a different way, make sure that you check out the ASJ Open Forum website, ASJ website. You can also subscribe through Apple Music and hopefully soon enough through Spotify. So thank you all for tuning in. Thank you all for the discussion and taking a night out of time to discuss some more content from ASJ. We look forward to seeing you back in 2 months' time online. Have a good night, everybody.
Good night.